and Pinky Hugs, LLC, which is a mother-daughter writing and film production firm specializing in social justice-focused documentaries. She's a recipient of the 2016 AARC Distinguished Public Service Award, also a member of the AARC Minorities in Cancer Research Council and of the African Organization for Research and Training in Cancer, Director of the Advocacy and International Engagement for the Globothon to End Women's Cancers, and an active participant in numerous other initiatives. With strong relationships throughout advocacy and research communities and a long-standing engagement in international health, Dicey's activism is driven by a commitment to global health equity. So welcome everyone, and without further ado, presenting Ms. Dicey Scroggins.
Good morning, can you hear me?
Yes.
Can you hear me?
Yes.
I can.
Okay, I just want to make sure I've turned my sound up as high as it can go. Please let me know if suddenly you can't hear me. It's my real pleasure to be here this morning and just to chat a little bit about patient advocate engagement in clinical trials and research. It's really essential. And so these are just some general facts. Some of it is information that I share when I'm actually training advocates, and I've worked with advocates all over the world, so and particularly through aortic in Africa. So good morning again. I'm not going to read this tribute, but as a survivor of ovarian cancer and someone who really focuses on benefit to patients and survivors, I always start with something to sort of ground us, because the reason that we're all here is to do for patient benefit. So it's really good for us to look at, to think about the kinds of things that patients contribute and what they go through on a daily basis. And it varies certainly by region and parts of the world, but it is difficult wherever you are. Okay, this is just a picture that my daughter and I took in 2005. We were in Kenya and we planted a tree on the Masai Mara that was for survivors everywhere. And we think about it growing strong. Okay, so the purpose and objective, we just want to, in this talk, one of the things that I was asked to do is to think about enhancing the awareness and understanding of patient advocate engagement in clinical trials and research, just so that you know how we can become engaged and why. So we want to understand some basic tenets of advocacy, key components, and just to envision and fuel the promotion of real patient advocacy throughout Africa, and then to understand what some of the tools are and so on that we need. And we'll talk about all of those things just a bit, and hopefully there will be a little bit of time left for question and answers. So what I'm going to try to set up a little bit today as we talk, and you can stop me and ask questions if you like at any point, but we will leave a little time at the end, is a framework for patient advocacy on the continent. This is not the framework. It's just something to start with and what we might move from. So we're going to touch upon some just basic elements, somewhat as it's practiced in the U.S., but elsewhere as well, but focus on what is actually doable for specific African settings, because things will be different by country, continent, locale, and so on. Please feel free, I always tell people, I don't care where I'm training, to feel free to liberally borrow from whatever exists, but just make it specific to your own setting. You don't need to reinvent the wheel. We just need to make sure that what we're going to talk about today is usable on African roads and byways, but you don't have to reinvent. There are many, many tools out there that we can use and adapt to various settings. So, why would you support patient or research advocacy? What is what is its value, and why is it something you want to do? And the truth is that if you have good patient advocacy and research advocacy, it really strengthens the whole process. It changes the way that researchers see patients and our needs, because we can tell you what our needs are and what we're actually experiencing in the real world. And it really keeps patients and advocates at the center of the research and the thinking, and that's where it should be. So advocates actually put a face on the disease. You're sitting there in front of people. It's very hard to not understand the urgency of good care and good research when people are looking you in the face. And we give a voice to people who can't be there. One of the things that patient advocates do, and particularly research advocates, they make sure that you hear the voices of other people, because you're only going to have so many people who will serve as the research advocates. Every patient and survivor can't be there. But if we do our job well, we are speaking to all of them based on experience and so on. We ask questions that are very specific to how we have experienced cancer that no one else would know. So we have a unique bit of information and expertise. And we create a sense of urgency just by being at the table. You can't see someone there and then not realize how urgent it is that we do the right thing. The other thing that's really important and is very different in different parts of the world is that we form really respectful alliances between researchers and advocates. And it's very different in depending on where you are and what the culture is and so on, and the differences sometimes how we separate patients and the general public maybe from doctors and researchers and so on. But we need to make sure that we all understand that we bring something really valuable to the table. And one of the most important things that patient advocates do and research advocates is that we provide hope. We let people know that someone has survived it and that these are ways that we can make sure that more people survive it. And when you have patient advocates involved in your research, the trials tend to be more focused on the things that are really important to patients. They're trials that patients are willing to accrue to, and you have greater benefit to the general population. So what value-added expertise and services do patient advocates bring? They bring strength of common goals. We come with a common goal, benefit to the patient, benefit to the general population. We talk about access to the knowledge from advocacy communities and constituents. So you bring the collective knowledge from many, many people. The personal real life experiences that no one else has, the passion that clearly advocates have. And to be a patient advocate or a research advocate, you don't have to be a patient. We'll talk about some of the other people who are part of this and again, that sense of urgency. So what research advocacy is not and requires. It's important from the beginning that we have some understanding of what exactly patient advocacy is and how you can use it. It's not a cure-all or a be-all, but it's extremely important. So it is a partnership between advocates and researchers, and it really does have to be a partnership, and it can't go one way. It's a natural alliance of individuals who have goals that are very much alike, but have different skill sets. Researchers bring one thing that's extremely valuable, advocates and patients bring something else that is extremely valuable. And it's really necessary for the most patient-focused research that you can do. It's not easy. It's not for somebody who gives up easily, who is easily discouraged, because the building of relationships is one of the most difficult things that we will find in certain locations because advocates or patients have not been in the position generally of walking up to a doctor and asking certain kinds of questions and being as forward in some ways. So it's not an easy thing. It's not something that you say, oh, I think I can do this, and you sort of just step in without training. There's lots of other things involved. It's not a short-term project. It really is a long-term commitment. You come into this thinking that, you know, it's going to grow and whatever. I've been involved for about 21, maybe a little bit more years, and I learn something every day. It's not free of cost. It costs to be an advocate. It costs to travel to various events and to do things and to have an infrastructure. So it is not free of cost. What it requires is dedicated advocates, or really a volunteer force, which is not necessarily the same as saying an uncompensated one. So that you do need to compensate advocates in some way, but you have to have advocates. You have to have people who are willing to do this work. It requires a supportive structure in terms of research, a research structure, that system that wants advocates involved. And this is a really good time for patient advocacy and research advocacy to be discussed in terms of research, cancer research throughout the continent, because we are beginning to see real strides in terms of research. So rather than the example that's happened in some parts of the world, advocates didn't become involved in the research until later on in the process. We can develop as advocates as long on the same track that the research system itself in Africa is developing and flourishing. So that is a real advantage. It's an evolving state of genuine mutual respect and acceptance. There's ongoing training. As long as you're an advocate, you're going to be training for something, and so will researchers in turn and the general public. And it's a real commitment, and there are all kinds of commitments that it includes, an individual, private, public, the time, financial, getting to places, and so on. So there's a lot that you do have to think about in becoming an advocate. So given all of that, and I know I've said a lot really quickly, and there are lots of slides here, and some of them we'll skip through very quickly, and some are just here for resource, and some we'll talk about a little bit more. But who chooses to be a research advocate or a patient advocate? There are just lots of people. The first people that we tend to think of are patients, survivors, and their families, and the caregivers. People from every walk of life, everyday citizens. You don't have to be a scientist. You don't have to have a certain educational level. People who are curious, willing, and want to become involved. You do not have to have a background in science. Often advocates wonder and think they don't have the skill set. And if they're committed to their community and committed to the survival of those in their community, then they can help and they can become advocates. So you have to have people who are clear communicators and people who listen, and people who have some connection to the community. And you have to have the ability to read, write, speak, or somehow communicate in the language of research documents and the population that you're serving. So you need to be able to communicate well and communicate with those that you hope to serve. Hello? Okay. Does someone have a question? Hello? I think I'm getting feedback from you. Okay, anyway. Members of advocacy groups are involved in other types of advocacy or activism. You don't have to be involved in a cancer research group in your community in order to be a good advocate. You might simply be someone who is involved in other kinds of things in the community. And becoming an advocate might be the first thing that you do that really is for the public good. Scientists and clinicians often, who are affected by cancer, are often become research advocates as well as scientists and so on. As a matter of fact, what I've noticed when I've been at aortic and training research advocates, I've noticed that there are more scientists and doctors and clinicians who come to the training than tend to do so, for instance, in the US. Then it can be anyone who's interested and has the time and the ability to commit to ongoing training and wanting to do the public good. Okay. So how do advocates prepare? All over the world, they'll prepare slightly differently, but these are some of the things that are really helpful. Being as fully participatory in your care and health decisions as possible, specific to settings. And I know that there are places where people have greater ability to participate in care, but being someone who wants to participate in their care and doing so as much as possible. Just researching, learning about all things cancer and becoming an educated consumer. It does not mean that you have to be able to understand all the things that are going to be said when you're looking at a protocol or when you're talking about research and science and so on, but you want to become educated as much as possible. Being actively engaged in something in your community so that you have a constituency that you can bring information back to and from which you can gain information, because this isn't all about you as an individual advocate. Very little of it is actually about you as an individual. Learning how to network, going out and sharing ideas and getting ideas from other people. You can't be a shy advocate. And then just reaching out to others who certainly are looking for ways to assist and wanting information and so on. Seeking learning and training opportunities. And if there are none, one of the things that we can do as people who are engaged and who want to become advocates and want to help the other survivors and so on, is we can create our own opportunities for training and can talk about that a little bit later. And sort of answering the call. When you know there's a need, just being willing to be out there and receptive to the call. And the obligation that you have as an advocate is to focus on the collective. It's really important that as we train advocates and as you work with research advocates and other advocates, that you understand that we're focusing on the collective, not our own individual stories. Our individual stories might be powerful, and they certainly are part of what we share. But more importantly than our own individual stories, we're talking about the collective of many people who will not be able to be at the table. So we can't just focus on ourselves. We may share our stories as illustration, but the real picture, the broader picture, is what we are there to share and to represent. And we start with the community, a constituency, and we always, as research advocates, as patient advocates, come back to the community. We can't leave the community and then feel that we represent them. We have to create and maintain two-way communication and always have education mechanisms. So we have to make sure that we communicate as clearly as we can with the research, with researchers and that element of scientists and that element of the research agenda or research process. And we need to make sure that we're getting communication back from them into our community. So we facilitate that engagement between the community and researchers. And one of the things that is extremely important, it's all over the world is important, but it is particularly important, I think, here in Africa as we start really developing research advocacy, is that we develop a pipeline, that we can't just train 3 people and that be done. We've got 3 people in one country and 2 people in somewhere else, that there's an obligation when advocates are trained that they train others. One of the things that we've done at Aortic when we provide training for advocacy, both research and other kinds of advocates, is that we actually ask advocates to train a certain number of advocates over the next year or two. For instance, if you're trained through aortic in 2013, we might have said over the next 2 years, we want you, and we'll provide you with all the information and all of the material that you need to train, and I'll make a number up. We might say train another 30 people or another 50 people or whatever seems reasonable. And some people make that goal and some don't, and you can train in many ways, but we have to develop a pipeline or we will never have enough advocates. The other thing is that we need to mentor. Advocates need to mentor other advocates and bring others along, and the whole research process needs to mentor advocates and patients. Okay. So each research advocates have a lot of things that they need to be aware of and to understand and to think about and so on. And one of those things is patient protection and research ethics. So we talk about education. This is one of the things that advocates become very much educated on and are very much involved in. So I'm just giving a few examples for consideration just because it's an important element of what we do as research advocates. And here, this is U.S. History of Research Ethics. It only given as an example of these are the kinds of things that that you learn that we need to understand so that we understand how people might be reluctant to go into research or what they think about research and so on. So we need to be aware of all of this so that it doesn't have some of these things none of these things will happen again. Okay, here are some of the codes of ethics that are used all around the world, and they have to do with informed consent and, you know, what's of real value and what's unacceptable risk. Because one of the things that patient advocates always do is we think of risk-benefit, you know, what's the benefit versus the risk and so on. So we do have to balance those things as we are looking at material and see ultimately what will be good for patients. So some of the criteria for ethical research that we as patient advocates and research advocates think about are the social value, scientific validity. Our patients select, and here it says subject, and I put quotes around subject. So I hope that throughout Africa you will adopt the practice of not saying subject. Written into most of our codes and so on in the U.S., we have the word subject, and whenever I see subject, I say participant or patient. So we want people to know that we know they're human and so on. So I hope we will veer away from the use of subject. But anyway, fair patient selection, participant selection for trials so that everybody has an opportunity to benefit and to participate. Then you want to balance the risk against the benefits. And then independent review. Someone who does not have a connection or cannot benefit from this should be reviewing all of the protocols and all of the trials and so on. And informed consent, which I'll say a little bit about in a few minutes because patient advocates do focus a good bit of their time on informed consent. And respect for enrolled, again, here's that word subject, the respect for all of those who are willing to participate in clinical trials, because if we didn't have participants in clinical trials, we wouldn't have trials and we wouldn't have the benefit. So clinical trial participation is a really powerful form of research advocacy. Often people don't think of it as research advocacy. They think of it more as, you know, something that people might or might not do, but it's really a strong form of research advocacy. And in order to have people in the become research advocates and become participants in trials, certainly we need to have an informed consent of some kind. So I'm calling this an informed consent detour because I'm going to veer off for a minute to talk a little bit about informed consent. You know, what is informed consent? Why is it necessary? You know, what is it intended to provide? What has to be in it? And I'll have a list in a few minutes of what needs to be in it. How should it be conducted and whom? And what should be considered or promoted in the absence of a formal consenting process? So an informed consent is something that is extremely important in terms of making sure that individuals who are asked to volunteer, you know, this human resource, which is our most valuable resource, understand exactly what they're volunteering for, what the risks are, what they will have to do, whether there will be costs, and so on. So it is intended to provide all of the information that would allow a person to say, yes, I want to do this, or no, I don't. So the consent forms are very different all over the world, but these are, I'm going to just talk in a minute about some of the things that we want to make sure are always included in the consent form. So these are some of the things that we have to have, or the things that are required that be a part of consenting in the U.S. is, you know, an introduction, something that tells you what the study's about. We emphasize the fact that this is voluntary and that whether you agree to be in a clinical trial or not, that you will not be penalized in any way. Your health care will not be, your care won't be jeopardized in any way if you decide not to. You describe the study, you tell how many people, you talk about risk and all of these other things. There's a statement that tells you this will be confidential. there's something related to cost and so on, so that you know if there will be cost to you. There's something about getting out of the trial and what we'll do with significant findings and those kinds of things. But one of the things that's really important that advocates emphasize, research advocates emphasize, is that informed consent is not just a document. When people say informed consent, they tend to be talking about this document that gives all of this information that I've just talked about. But it is also a process, and the process is equally important as the document. And the process is one that I haven't listed the steps of. We could talk about a little bit if we have time, if you're interested. But there needs to be a process where people have a chance to digest this information. And research advocates and advocates in general are really helpful, both in looking at an informed document. So as you develop your informed consent, please have former patients, have people who have been through certain things and who would know what would be acceptable maybe in the community and so on. Research advocates, have them look at the document and help you with the wording and so on, and inclusion and in the process. So there's some speculation on reasons for disparities in treatment and trial enrollment and care. And I added this here because around the world this may be an issue, and it's an issue for various reasons, that sometimes people are reluctant to participate in trials. So these are some of the things that you might think that we think about in the U.S. and are thought about in other parts of the world as well. So I just put them here just for a matter of information. And patient advocates and research advocates sort of focus on these things, understand what these things are, and then try to talk to people in the community so that they can explain to them how these things might affect them, and talk to researchers and people who are a part of the research process or enterprise to make sure that these things are handled fairly and that there isn't racial and other bias, and that patients and physicians are communicating in a certain way, and that everybody has equal access. So that's one of the things that's really important in terms of research advocacy, making sure that everyone has equal access. And so what are some barriers to clinical trial participation and care in specific settings? How can you overcome these? Each country, each region, each cultural group will have to decide, what is it that will or will not influence people to become a part of a clinical trial process. And there will be different in every country. There'll be different in parts of the country. There'll be different regionally. There'll be different in terms of languages spoken and so on, and traditions. So be very careful in terms of thinking about, take a lot of care with your thoughts about when we build this process, what are the things that would be barriers, and as much as possible anticipate them and try to ameliorate them, to get rid of them, to eliminate or reduce them. And opportunities for patient or consumer research advocacy. In the U.S., sometimes we call patient advocates consumer advocates because we're the people who consume the care that is a result of all of the trials and so on. So how and where do patient survivors learn research advocacy skills, and where do they get to practice them and refine them? So in order to be heard, advocates are sometimes on institutional review boards or ethics committees or some other name that you might have from this body that looks at the trials to make sure that the research is ethical and that patients are properly protected. They might be on a review panel to decide which research will be funded. There are all kinds of, it could be a part of the research team. Often the advocates are a formal part of the research team. They're not just advising the team, they're actually on the team. And they could be on other kinds of groups. So advocates then share their stories, our stories, and I think it's our stories versus the personal, usually speaking to the collective. We want to make sure that advocates know they should be persistent and tenacious, but not verbose. The idea is not that you just talk, that you get there and sort of filibuster. The idea is that we get there and that we are persistent about the things that are important, but that we don't just pick up airspace. And then we demonstrate our concern and passion, hopefully without anger, because we have to assume that all of the clinicians, all of the researchers who have decided to focus on clinical research are there for good purpose. They're there, we have to assume good intentions. And sometimes, things may not look like that, but we have to assume good intentions. And we're there to build relationships and not to mark care. So we always want to keep our eye on the prize, and the prize is benefit to patients and the public. So there are just many, many, many ways to serve, and I'm going to talk about a few of them. I'm just listing some of the ones that are currently available in the U.S. and other parts of the world, and some of them are available currently as we speak in Africa, and some of them are ways that you will build new ways. So these are, as I go down this list, it's not just one thing. There are many, many, many ways to serve. And what I've listed here are just some of the ways to serve. These are not all of the ways. These are just a few of the things to get you thinking. If what you think about is only having patient advocates, say, on a review board, now you can see that there are other kinds of things or ways that they can serve. Certainly they can serve as part of a community-centered health organization. They could be on the research team. They may go what I'm calling Capitol Hill, means go talk to legislators to see what we can do in terms of the law and legislation. They might do site reviews, meaning go to a site to see if the equipment is appropriate, if the trials are being handled appropriately, and so on in many ways. And these are literally just a few, a sprinkling of the opportunities that we have as research advocates. So something here again to consider is what other places or types of events would work in specific countries or regions. So what would work in Washington, D.C., where I live in the U.S., might not necessarily work in a place called Bishopville, South Carolina. Washington, D.C. is a large city. Bishopville, South Carolina, which is where my family is from, is a very small rural community in the South and in South Carolina, of course. And so what would work there won't work necessarily. What would work in one place won't in the other. What happens in Washington is not necessarily how we're going to train research advocates and how they're going to work in the other place. And the same is true, certainly even more so when you think across a huge continent. Think of what other types of things you might be able to work on in other places. And advocates must develop individual advocacy plans that are specific to their locale. It's not a continent-wide engagement. You may engage in terms of the whole continent, but there has to be very specific planned exercises and ways of training and ways of working with the research enterprise in every locale. And so one of the things is that, just developing this individual advocacy plan, and researchers can assist the advocates in doing so. And so you want to know, so why do you need a plan? What are you going to put in it? What are the elements going to be? Who else do you need to call? Because none of us do these things alone. This is a collective venture. What do you want to achieve? What things do you need that you don't have to succeed? And what's going to be the benefit of your plan? And then in review, is your plan realistic and doable? So you develop a plan so that you can see if all these things work. You can develop a plan so that you can see how you can best serve. But it is really important that every advocacy group, as well as individual advocates, decide how I'm going to work. These are the things I will need. Who do I need to contact in the community? How can I network best? How can I best serve my constituents? And how can I make sure that all of this ends up with benefit to the enterprise, but mostly benefit to individual patients? So one of the mechanisms that we use here in the U.S. and I think is ideal for use in various communities in Africa is community-based participatory research. The community is at the center. It is a really ideal research setting. So you form partnerships of equals. So the advocates, the community-based organizations, individuals who are ordinary, everyday working people in communities partner as equals with researchers at various institutions and so on. It's really a collaborative approach. The important thing here is the community, it's focused on the community and it's driven by the community. The ideas for the research come out of the community. It's overseen by the community and so on. And in these kinds of settings, there's a recognition of the unique strengths and gifts of each of the groups. And what's important here is that advocates and the community leaders and your neighbor down the street, or your, someone that you see every day passing, or that you're on the bus with every day, might have something that's really valuable to add to this process. Might be able to tell you, what, I know what you want to research is important, but let me tell you what I hear people saying every day as I sit on the bus on my ride to work. These are the things we are interested in. And those kinds of things can boil up and become actual research proposals and become funded research. It asserts the importance of full community participation, and the research ideas flow from the community and the community concerns. It's extremely important, and I think an ideal way to certainly move some research advocacy in Africa forward. It's important to engage communities, maintain their interest, and to build trust in the research system. And patient advocates are here. When I say patient advocates here, I actually mean people from the community, advocates who come out of the community. And they don't necessarily have to be survivors. They don't have to be people who have actually experienced cancer themselves. They might be caregivers. They might be a storekeeper who has seen his neighbors, go through the journey with cancer and so on. They just are people who are interested in your community, who have those ties, but it's really important that you engage them. And please, as you begin to do your research, engage communities before you want to ask something from them. So engage them early, engage them as soon as you possibly can, before you have an ask. Make sure that you have something to give. And when you do research in the community and you engage communities, make sure there's something left. If you're working with left of infrastructure, for instance, important for an organization. Let's say you're working with a small community-based organization that low resources, have various needs that you might be able to help with from your institution. Make sure that when your research or your work with that group is done, that there's something left of value to the organization that they can continue to do their work with, and that will improve their ability to serve the community. Really important. So the unique perspectives of research advocates, there's so many things that are very different in how we see things and sometimes how the world sees things outside of being in the research advocacy field and outside of having the experience of being a survivor or a caregiver or a family member. So some of the practical concerns that we have and the things that we bring to the table are questions that we might ask, and I'll show an example. There are a couple of pages later, you'll see examples of questions that research advocates, the patient advocates will ask, and PA is for patient advocates here, that nobody else would maybe necessarily think to ask before you bother to get the research on moving, and that you have a protocol, a proposal you're thinking about, a research trial that you're thinking about. Advocates will ask questions that will help you refine it and make it better before it gets to the point that you're trying to fund it and then there's this big hole in it because patients would not want that kind of care or whatever. People and groups, patient advocates want to engage. They can bring people in that no one else can bring in. Development of a presence in the community where patient advocates will train others, and how will they do it and why, but we can develop a system where patient advocates go into the community and train others, provide information. And sometimes the information they're providing is awareness of cancer, that these are some of the signs and symptoms and some of the things you need to be watch out for. These are the things you need to do if you suspect something. These are some of the ways you can get care if you don't have the ability financially to do so, and so on. So there are many, many ways that patient advocates can work with the community and help others and train them. The time and commitment effort, organization and a schedule. We have to have an organization and schedule. We have to organize ourselves and have a schedule for doing things because it's not haphazard. Personal considerations. Patient advocates are individuals who have lives outside of cancer and their commitment to doing good. So we have to consider that as well. And we need to think about funding for efforts because these efforts are not free. It costs money to make flyers. It costs money to find a place to bring people together to share awareness and so on. It costs money to travel to various locations to provide information and so on. So we do need to think about funding. This is not a free enterprise. As researcher advocates, areas of focus and some of the types of questions we might ask. I said that patient advocates might ask questions that nobody else would think to ask. And if someone else does ask, they'll ask them from a different perspective. And these are some of the kinds of questions. Now, these are questions that that I might ask sitting at a protocol review, a clinical trial review, or concept review. But some of these are the same kinds of questions that would be asked anywhere in the world if people understand, once we train people to understand what all of these things mean and how important they are. And one of them is, what will and can this research mean? One of the first things that come to mind to patient advocates and to research advocates is, what will this research mean in terms of care? Will it change practice? Quality of life, and survivorship. So survival and survivorship. Patient advocates tend to think of both survival, which is how long we will live, and survivorship, how well we will live, like the quality of life element. Sometimes researchers forget or minimize thinking about that quality of life element, and increasingly patient advocates will bring us back to that and say, okay, but what does it mean to my life? Will I be able to work, and all of those kinds of things. we'll ask things about why a particular drug was selected. How is this trial different than another one? Because patient advocates, again, and research advocates become very much educated about the program and the system, and they're aware, with the continuous education and so on, they're aware of trends in trial design and so on. So they will ask some of these questions. They'll ask a really important question of, can this trial accrue sufficiently? Can you get enough people on this trial for it to yield usable results? And that's extremely important, because if you can't, the best trial in the world is worth absolutely nothing if no one wants to enroll, or you can't get enrollment. So one of the things that patient advocates are really good at, research advocates, is determining what would be acceptable in the community and helping you think through and work through a plan for accrual and a plan for going out and getting people to enroll for enrollment and so on. Here are some other questions. I have several things here, what some of the barriers are, make sure all populations are included, making sure that if you exclude people, there's a reason and so on. For instance, another thing that we tend to do is just look at exactly what it is that you're asking people who participate in the trial to do. For instance, and I made this number up, 20 scans. If there are 20 scans, somebody's going to ask you, are 20 scans necessary? Are they safe? Will potential participants agree to them? So you might then look at that and say, you know what, don't need 20, we need 2 or whatever. So those are some of the kinds of things that people will participate, will ask about. And then they'll ask about the side effects, and you say, oh, they're mild, and you tell us what the side effects are, and someone might say, well, that'll be very difficult for the patients to then be able to go to work the next day and so on. So they'll ask those kinds of things. They'll ask things about, if you use terms like non-inferiority trial, they'll ask, what is it, what does that mean, and so on. So those are some of the questions. But it's really important to remember that actual focus and questions are going to be country, culture, population, and research system specific. These are just some of the kinds of things to give you an idea of how well trained patient advocates are and how committed they are to making sure that things are safe for patients who might participate, and that we get the best results and the things that will best serve patients. So I'm closing up here a little bit. In summary, I've talked about a framework, and the framework would include public and private support and investment. Somebody's got to invest in this, and the public needs to understand the investment. So it requires some marketing, actually. A research system that values patient advocates and embeds them. So you have to have a system that understands we have value. So part of the goal is that we make sure that the system itself understands that we're important, and we're not just there for window dressing or just there because someone says you should have us, but you understand the value and it's embedded. That the patients, survivors, family members, caregivers are willing and able to become research advocates. Again, because it's not an easy thing, that make sure that people understand what the commitment is, that there's going to be ongoing training. There has to be a commitment to service and something that goes beyond your individual issues and so on, and talks to the common good. And consideration of the very practical sides of advocacy, which have to do with time and commitment and family and balance and your life and so on. So, I just thought, so what's feasible, what's doable, and what's most urgently needed? What is feasible is building a strong, active network of research advocates. It's absolutely doable and feasible. In fact, construction has already begun with great enthusiasm in various parts of the continent. There's some wonderful organizations and individuals that support research advocacy and so on. It must be country specific and African led. I think it is really important that we don't sort of parachute in, tell people what to do, and maybe if they don't do quite what we want, we're then not happy with them, rather than thinking that we provide support and guidance from other countries that have a more robust research advocacy network. But it has to be driven, it has to be led specifically from the continent. That's where the impetus is. We can't go in and do it and say, this is what we do, so you down do it. This is an example of what you can use, and this is the framework that's appropriate. And let me help you try to tweak it and tailor it so it works for you, so you're not reinventing the wheel. And it's easiest to begin with general patient advocacy. Many research advocates start out as support or education advocates who support other survivors and so on, and help with education and awareness. But some people go right into research advocacy and do it well. And here, what I think of as most urgent, some of the most urgent, and among the most urgent needs, I guess. is that research structure. I know I've said it several times, but I think it's really important that we give more than lip service to a research structure that supports, encourages, and incorporates and embeds advocates and research at every level, and that we understand the core value-added components, what we bring, that we really understand that and we just don't talk about it. Active development of a core and a pipeline. So we have to invest in developing a pipeline, which means ongoing resources and ongoing time, and a progressive training program that's built through collaboration and networking with people all over the world. There's so many resources that are available. There's very little you'll just have to invent. You'll have to tailor things, and some level of or mechanism for funding, because again, it does come down partially to the money. And so here are just some sample resources, both for advocacy training and research training and so on. AACR and ASCO has a methods in clinical cancer research program workshop, and they train early career researchers on clinical trial design. And something that is very interesting about the program, unique and wonderful, is that they also have fully vested, active patient advocate faculty who has the same responsibilities as all of the other all of the other faculty who are involved, and they also work with early career researchers on design. So this is something that some of the early career researchers, both from Africa as well as research advocates, might be interested in becoming involved in. The ACR Scientist Survivor Program, it brings advocates from all over the world and enhances their skill sets, and they engage with researchers. Each of them will have a scientific and a advocacy mentor that they will have long-standing relationships with. Advocacy training at aortic conferences. It has been a day-long, sometimes two, training that we plan to have an ongoing piece, and it builds, there's an advocacy consortium that's been developed, and we ask advocates when we train through aortic that they go on to train others. It's a specific one of our, in quotes, requirements that you go on to train others. The aortic website has lots of resources. NCI, U.S. National Cancer Institute, has programs, online training, all kinds of opportunities. There's a program called Survivors Teaching Students, Saving Women's Lives. This is a program of the Ovarian Cancer National Alliance in the U.S., and it trains survivors and their families to teach medical students and other healthcare professionals, including researchers, about ovarian cancer. This can be applied to any science. So you can set up a program like this for any cancer and have actual research advocates or advocates in general and families go out to train others about the real life experience of having cancer and what it means, and that will influence ongoing research. So advocacy is a global affair. It definitely is. I'm going to talk about one type of global event or type of global organization or movement that I happen to be involved in, which is the Globathon. It's an unprecedented effort to expand awareness and advocacy associated with women's cancers, and it's truly on an international level, and expanding its focus beyond women's cancers to include global health equity as well. And in its second year, in 2014, there were over 186 million people who were reached. There were approximately 80 countries who hosted Globathon events and 156 partner organizations. And significantly, and this is really significant, in its first year of existence, in 2013, more than 14 countries on the African continent participated in the Globathon, and which was a fairly large percentage of the number of participating countries. So low resource countries as well participated highly. So we had a mixture of countries all over the world, and the aortic was one of the main drivers in terms of getting African countries involved, and continues to be. The Globathon is one of these events that it's for women's cancer specifically, but it's just an example of the fact that advocacy is global, and certainly the Globathon is largely advocacy driven. And here is an example. Again, we had the Globathon sponsored an event at the U.S. We had this event that we wanted to make sure that all over the world people would understand, and it was, I think we focused on cervical cancer, and it was held at the UN and was well attended, and we focused on a lot of what was going on in cervical cancer, both in Africa but all over the world. And this is just an example for me of the power of collective action and networking. Several years ago, my daughter and I, again, we were in Kenya and some other places, and we came across this women's collective that supports members through basket weaving and educates others through plays. And there are very few men. I don't know who the young man who's standing there, but he doesn't live in the village. Almost all of the men in the village have died. There are a few young boys there. And the women courageously, even with the stigma of AIDS and so on, have plays that they put on for close community, for communities that are close to them. So they do these plays and they go there, and even with the stigma and so on. So as I looked at that and just was in awe of them, understood that nothing is beyond the reach of a group of dedicated, passionate people anywhere and under any circumstance on the planet, and that's absolutely true. In closing, the presence of patient advocates is a continuous reminder of why we are here and really drives the focus of relevance. A researcher says this after interacting with advocates. And here, just as a greeting from my 3 little advocates in training, these are my grandchildren. And just thank you for working to change the cancer landscape and burden in Africa. And here's some of my information, and pinky hugs to all of you. Patient advocates and researchers are natural and necessary partners in research and discovery. Please remember that. And together we can make a real difference. Of this, I'm absolutely certain. Here's some acknowledgments, organizations, places you can get information, and so on. And I always thank Alice Beers, who was my first oncology nurse. Nurses are important to cancer survivors and their families and caregivers all over the world. Thank you.
Thank you so much, Daisy. So we'll open up for Q&A now. So if anyone has any questions.
Hello. Hello, my name is Shola. Can you hear me?
Yes.
Hello. Hello.
Hi, yes.
I can hear you.
Oh, okay, good. Yeah, thank you. First, I want to congratulate you for a very, very wonderful presentation. But I want you to take a minute or two to speak to advocacy that could be targeted at sources of funding for research. That's a big problem for us, well, specifically in Nigeria, because we have quite a few foundations that are coming up, they are rich, but I don't see them targeted with messages to encourage research in areas that are, that are in desperate need. We have the Dangote Foundation is rich. We have the T.Y. Danjuma Foundation is also very rich. Folarin Shualakija also has a foundation. So how does one develop the skill to target them and encourage them to fund healthcare research? Thank you.
Okay, I think that's a really important issue. And I think one of the things that we have to do, and I say we, I mean all of us who are interested in the public good and benefit to patients and so on, is we have to tell people what we need and what we want. We have to be very clear about it, irrespective of how powerful they are and so on. And you will have no better partners in doing that than actual patients who are trained. It is amazing what a difference patients in the U.S. have made. And we have not always been involved in research in a really active, positive way where everybody was, sort of working together and understood the value. But we have made it a tremendous difference in getting funding from organizations that weren't funding before and from our government in terms of what they fund in terms of cancer research and care. So it is important that you get the general public involved, but that we are not shy in saying what we need and what we want if organizations are going to be involved with us. And I don't know if that answered your question at all.
Yeah, that was quite helpful. Thank you very much.
Exactly. So when you're on a track, you are deemed to have scored the minimum for that track. The question is, what is the minimum for your track?
I heard someone was speaking, but I couldn't hear them.
Because I went down and you said I should that Ebola and I it's the same.
I'm so sorry. I can't. I know someone's speaking, but I can't hear them. I'm hearing some kind of feedback, and I can't hear the person. I'm so sorry. I'm so sorry. I can't respond because I can't hear.
So this is Sam from NCI. Thank you very much for giving this really, really wonderful talk. And it really helped me understand the role of patient advocates. I have a question about community advisory boards. I lead a study called Emblem, and as part of our implementation plan, we engage the community by inviting the community to nominate people who then became the community advisory boards. And they had the chance to ask questions and provide explanations to the community. Do you have any comment about that? And
I do.
Would those be patient advocates as well?
Yeah, I do have just a couple of thoughts about that. I often hear comments about community advisory boards, and one of the things that most organizations, particularly, well, not particularly, but most organizations set up whenever they decide they're going to work with researchers or work with the community, is that they set up a board that gives them some authenticity and that of people who reflect the thoughts and the community at large. One of the things we have to be really careful about when we set up community advisory boards is that we really have the voices of the community, and that we don't handpick people who far too often I think people get handpicked who are not really of the community in the sense that they are engaged in we don't necessarily want the person who is in quotes the most educated or the person who owns the biggest store, that kind of thing. We want a variety of people. And so I think we don't get enough diversity on a lot of community advisory boards. And I think that's in the US and elsewhere, that, you know, we tend to get the PhDs and the doctors and the other people on the board, but we don't get the storekeeper and the person who lives down the street and grows vegetables in their backyard, and, you know, and so on. You know, my mom lives in Washington, D.C., and she's from rural South Carolina. She still grows vegetables in her backyard in the middle of the city. Nobody's ever come and asked her to be on a community advisory board. She knows as much about that community she's been in for 60 years as anybody in the community. So we have to make sure that we get people who are authentically able to give voice to the community. I think they're good. I think they're useful. I just don't think we people them very well. Does that answer all? I just don't think we are very picking people to be on the community advisory.
Yeah, that's very helpful. I was just wondering if there are any papers written about that, you know, which one could, for example, refer to when thinking about setting up a community advisory board.
I'm sure there have been. If you would send me a note, I'll find some articles and send you. Yes, there has been research. And part of the research, again, goes to that idea that we need to make sure that the people that we decide to have on these boards are truly the appropriate people, because once the boards are set up, whatever the board says is sort of taken as that's the word of the community, and sometimes it really isn't.
I will do that. Thank you.
Hello. Good afternoon.
Yes. Hi, how are you?
Fine, thank you. I listened to the presentation and I found the details of the advocacy that you presented quite interesting. Hello?
Yes, I'm listening.
Okay. We here in Zaria, ABU Zaria are proposing to put in an application for the advocate to cover the Nigerian northern region, including, of course, the countries surrounding, such as Cameroon, Niger, Chad, in fact, even up to Benin and beyond. You know, we have here a Center for Development Communication where advocacy works in using the Theatre for Development strategy is much in use, and that's why I called to intimate you.
Oh, that's great. That's wonderful.
Yeah.
One of the things that that's great. How is that going?
You said? Pardon me?
How is the development of this going? One of the things that people have found in the U.S. and some other parts of the world, in the U.S. it's very hard to get funding for a program, a research program, a community program, anything like that, unless you do have patient advocates involved. And I think increasingly that's going to become the way everywhere. And they also want to know
That's
how
right.
they're involved.
That's right.
It can't just be that their names are on the paper. You're going to be asked how they're involved.
That's okay. We'll try and do all of that and include them and say as
Yeah.
progress.
Great. So that they're included in what we call meaningful ways, that they're not just there so that you see that you have them, that someone's going to ask you, what do they do? How do they do it? And may even survey them to see what's going on.
Actually, our approach here is community-based in most cases.
Oh, good.
We use the community-based and we use the languages of the people, the nuances of their speech, their expressions, because their cultural forms of communication are the tools that we put in use.
Absolutely. That's the way to go.
Yes.
And it really is.
Thank you so much.
Thank you.
Okay.
Are there any further questions? Okay, I think that's it for today. Thank you everyone for coming. Thank you so much to Dicey. If you would like to get in contact with her and you don't have her email, please email us at captc@cop.ufl.edu. We'll get you in touch. Thank you so much, Dicey.
Thank you so much for the opportunity. Take care. Have a great day. Bye-bye.
Bye.
Thank you. Bye.
Thank you. Bye-bye.